We know that there is a lot of research which is going on continuously in the field of pediatric endocrinology across the globe, and a huge number of publications which are there, which happens. But unfortunately, most of those publications do not result in changes in terms of our clinical practice. The reason for that is that we cannot go and look at each and every paper individually. So guidelines are in a way a bridge so that we can look at the current evidence available, and which will tell you whether you need to change your practice or not. And this is what the theme would be. So why do we review guidelines? Is that because this provides us information which is evidence-based. Now, most guidelines are by the leading experts which are there from the group. So today we're going to talk about guidelines which are coming from the International Society of Pediatric Adolescent and Diabetes, the multiple pediatric endocrine societies which postulate the SGA guidelines, as well as the endocrine society. So they are usually evidence-based, and they provide us some perspective as to what is relevant from a clinical perspective, and a huge amount of data is filtered from that regards. We know about what's happening in that particular field, and often it is very difficult to understand, interpret. So this is like something which is made easy for us to not go towards all that literature review, and we go from that perspective. So what basically we are going to do is to basically try to cover the various aspects which are relevant in terms of guidelines and that perspective. All of you can go and have a look at our website, learning.growsociety.in, which provides a lot of information about various aspects of pediatric endocrinology. We've got various courses available which provide insights and other tools for pediatric endocrinology. There are a lot of other activities like journal club, like grand rounds, as well as the lecture series which is there. There are publications as well as the mobile application which can be used from that regards. So today I'll be focusing about 3 specific topics. The first topic which will be taken by me would be on type 2 diabetes guidelines. Then we have Dr. Dhwani, who will be talking about the SGA guidelines by the International Pediatric Endocrine Society Consortium. And then Dr. Dhwani will talk about the gender discordance guidelines via the Endocrine Society, and how do we assess from an endocrine perspective largely from that regards. So as I said, we will try to focus about all this. What is the evidence, what is the state of art, and how we can implement it. So what we have done is that we have used cases to pose specific clinical query where there is a lacunae in terms of current practice, and see what these guidelines change, whether we need to change our management, our assessment, and other aspects on that regards. So when we look at a guideline, we have to particularly look at how much literature they have really reviewed. So that becomes important. Whether they have used a standardized protocol, which is the grading protocol for evidence, which I'll touch base about a bit in the next slide. What weightage is given to individual aspects, and whether there is any particular bias or not. So what guidelines we are talking today are based upon the well-known international bodies which have published so many guidelines. So many of them do not have all these issues. But whenever you are assessing, look at how much literature was reviewed, who were the people involved, whether they were showing any bias in that regards or not. And that's why this grading of evidence becomes extremely important. Now, remember that guidelines are not the all end all as far as clinical practice is concerned. Now, generally, guidelines tend to dictate that this should be done. Now, you should remember that this should be done in an ideal situation. Now, every child is different. Every scenario is different. There are socio-economic, racial, ethnic, so many issues. So we cannot just follow everything which is there on the guideline. We have to adapt them. Second, they do not talk about individualized care. So we have to individualize the management. As I said, more often they are community-based, and often feasibility issues are there. You have some complicated investigation or some very expensive treatment which is available, which you cannot utilize in your patients. So you don't have to really think that, okay, we are doing something wrong. So you have to basically go through the guideline and try to see what you can do within your resources. Important topic of gender discordance, and often we are now seeing patients who are presenting to us with issues with regards to the gender identity, and there's so many issues involved as to what should be done, who should be the primary person who should evaluate that particular scenario. How do we go forward, and what should be the evaluation approach, and what very importantly is the endocrine parameters to do, and what treatment can be done. So I have Dr. Vibha who will be talking about these topics and in detail. So over to you, Dr. Vibha, on this topic of endocrine treatment of gender dysphoric children.
Thank you, sir. Good afternoon, everyone. I'm here to present the endocrine treatment of gender dysphoria by the Endocrine Society. So let's begin with the recently encountered very interesting case of a 22-year-old female who visited to our OPD with the complaints of a discomfort in relation to her body since childhood. She described her gender identity as definitely not as female. She has consistent feelings of a more masculine identity. Her breast, her voice, menstruation, and misgendering as female were the main sources of her mental distress. So the main question that came to my mind during the OPD session was, what should I do? Because this was the first case I was looking into, and how should I manage this case? So, and is it really gender dysphoria, or is it some other psychiatric condition similar to the gender dysphoria? So the guideline clearly says that a diagnosis of the gender dysphoria should be made by a trained mental health practitioner. He should be competent in using DSM and ICD criteria for diagnostic purposes. He should be able to diagnose gender dysphoria and distinguish it from other similar psychiatric conditions like body dysmorphic disorders. He should be able to assess the psychosocially mental conditions of the patients. So let's see what are the DSM criteria for the gender dysphoria. It is a marked incongruence between the one's experienced or the expressed gender and primary and or secondary sex characteristics. A strong desire to get rid of one's primary or secondary sex characteristics and a strong desire to be treated as of another gender. So making a diagnosis of gender dysphoria, is it sufficient to start the treatment? Definitely not. The guideline clearly advise that the patient should fulfill the criteria for the treatment, and these criteria has to be assessed by the MHP, that is the mental health practitioner, and he has to confirm that it is a long-lasting and an intense pattern of gender dysphoria, and it has worsened with the onset of puberty. And there is no coexisting medical and social problem that could interfere with the treatment of the patient. And the patient is in sufficient mental capacity to give the informed consent to the treatment. And the patient has been informed of the effects and the side effects of the treatment, like the loss of fertility after the treatment, and the options to preserve the fertility, and she should give the informed consent. So what about endocrinologist? The endocrinologist should agree with the indication of the generous agonist treatment, confirm that the puberty has started, that is the pubertinal state should be greater than 2, and there is no medical contraindication to the generous agonist treatment.
So what are the usual hormonal profile in these patients? In terms of, do they have any abnormalities in hormone profile?
Sir, they have generally, if that outpatient was a female, they will have normal menstrual cycle. Everything is normal, but what they are not comfortable with their gender identity, with their gender assigned at the birth. They want to be treated like another gender. Everything is normal. Every sex hormone profile, every cortisol, everything is normal. But the psychosocially, they are not comfortable in their body.
Very important point here is that they do not have an endocrine disorder. We do not need to do an extensive workup
for this.
They are not DSD in that sense.
Their genitalia is absolutely normal. So our patient absolutely fulfill all these criteria. So we plan to start the treatment. But the question was, how should we approach the treatment? The guidelines clearly says that we should not start the treatment in the prepubertal period, because in the 80% of the patients, when gender dysphoria is diagnosed in the childhood, most of the patient, the diagnosis get reversed in the adolescence. So we should not treat in the we should not give hormonal treatment.
And the other big thing is that because of all this social media and other pressures, now the people who do not have the gender dysphoria also
Assume that exactly.
So that is why psychiatric involvement becomes absolutely important. It's a big decision to take.
And it is also important to start the pubertal suppression in the early onset of the puberty, because some of the changes are very irreversible, like the advancement of the breast stages and the appearance of the Adam's apple, that couldn't be reversed even after the treatment. So it is better to treat after the tenor stage 2. So what molecules can we use? GnRH analogs are used to suppress the pubertal hormones, and this for the puberty suppression, leuprolide, triptolene, gosdril, hysterine, the same these analogs are used, like we used for the treatment of precocious puberty. The protocol is followed as same. It is given like in the interval of 12 weeks and with a dose of same to 22.5, 12 weekly IM dose is given. The most important part is counseling. The patient should be counseled enough that there will be some physical changes during the treatment. There will be some and she should be asked like whether she has to continue with the treatment or she has to stop with the treatment. So we should be.
If you look at it, this is a phase-wise treatment.
Yes, sir.
So initially, first we have to make sure that there is no psychosocial. Once we do, this is a reversible form.
Yes, sir.
So you are just suppressing puberty for some time. And often patients may become problematic and okay, I don't feel comfortable, and then they decide that okay, my decision is not final.
Yes,
so
sir.
These things you have to do stepwise.
Yes, sir. So during the pubertal suppression, the monitoring is important. Every 3 to 6 monthly anthropometry, blood pressure and tenor stages is being monitored, and 6 to 12 monthly LH, FSH, estrogen, testosterone, and vitamin D levels are monitored, and every 1 to 2 yearly bone density using DEXA has to be monitored, because when we use GNR analogs, the sex hormones are being suppressed and it will cause bone demineralization. So bone density assessment is important. As Sir has already mentioned that it is a temporary suppressment of the pubertal hormones. It can be reversed at any time according to the patient's wish. It provides more time to explore their gender identity, whether they are comfortable with this kind of suppression without experiencing ongoing incongruent pubertal development, or they were comfortable with their previous identity. So it will provide some time for them to explore their gender identity. So what changes should we expect after the GnRH analog? So as it is a reversible suppression of the pubertal hormones, it will not cause the permanent suppression. It will only cause the breast tissue. The breast will become soft, like slightly atrophic. The menses will stop. And in boys, virilization will stop and the testicular volume will decrease. And there are some physical changes that are irreversible in boys. That is low voice, broad jaw, and thick eyebrows. So we counseled our patient that during this treatment, her breast will become soft and her menstruation will stop. So after the pubertal suppression, can we really start the sex hormone treatment now? Absolutely not. Again, the patient has to get a clearance from the mental health person whether she fulfilled the criteria for the sex hormone treatment or not. And the criteria for getting a sex hormone treatment is the persistence of gender dysphoria during the pubertal suppression. He or she is able to estimate the consequences of partly irreversible treatment, because when we start the sex hormone treatment, it will be a kind of irreversible treatment. and she or he has been informed about the irreversible effects and side effects of the treatment, like loss of fertility, and endocrinologist agrees with the indication of sex hormone treatment, and there is no medical conditions to the treatment. So when the patient fulfills all these criteria, then we can start the sex hormone treatment. So the next question comes, how should we start? How should we initiate the sex hormone therapy? The guideline clearly mentions that before starting the treatment, we should always evaluate and address the mental condition to the patient that can be exacerbated by the hormone depletion and the treatment. And they are, in the transgender female, when we give lots of estrogen, the thromboembolic conditions can be increased. The prolactin level can be increased. It can cause macroprolactinemia. In the transgender males, because of the high doses of testosterone, erythrocytosis can be caused. So we have to evaluate all these conditions. So how should we go forward? The plan in our patient, as she fits into the criteria of the transgender male. Transgender male is the gender assigned at the birth is female, but she is not comfortable as being treated as female and she wants to be treated as male. So she fits into the criteria of transgender male, and the plan is to give injectable testosterone, which is testosterone ethanoate, and we will give with a dose of 75 milligram 2 weekly for 6 months, as she is a post-pubertal adolescent, and will increase to 125 milligram and will give it to 2 weekly.
This is slightly higher.
Adult dose.
So
Yes,
adult dose is roughly 100 milligram
weekly. Yes, sir.
It's a bit higher.
And if due to some reasons or very compelling reason, we have to start the puberty very early, like during 13 or 14 years, we can start with a very low dose, like 25 milligram 2 weekly IM.
Why have they given 2 weekly and not 4 weekly? They have any.
So they haven't mentioned.
Sir,
I think they require more hormone to suppress the endogenous estrogen or some like.
But they are already on GnRH.
Yeah, but
they are on GnRH, and then you start the contra-sexual.
And once the adult dose is reached, we can shift to 12 weekly injection, that is 1000 milligram. And GnRH analog can be discontinued when once the adult dose of testosterone has reached and when they are individualized, well virilized. And if the uterine bleeding continues, even with the testosterone dose, we can add medroxyprogesterone with a dose of 10 to 20 milligram OD or BD.
So how would testosterone inhibit menstrual bleeding?
So it will.
So why is there no bleeding in PCOS? With the
anovulation.
But the high testosterone will suppress the LH test.
Oh, sir, but I don't understand why even with the testosterone.
You can have. Generally, 99% will not.
Okay. In case if there is it would have been, if in case of transgender female, the pubertal induction is done with a very low dose of 10% of the adult dose, and it is increased 6 monthly to reach the adult dose of 2 mg per day in 2 years. If it is a post-pubertal adolescent, we can start with a higher dose of 1 milligram per day for 6 months. Then we can rapidly increase it to 2 milligram per day.
You have to be cautious because high levels of estrogen can have a huge impact on the brain.
As well.
There's a very interesting story about a famous scientist called Turing.
Okay.
He was supposed to be one of the most brilliant scientists of all times, and a lot of work was done on that. So he was basically had a criminal case against him that he was found to be homosexual. So even in 1945 or 47 in Britain, there was a rule that if somebody is found to be homosexual, they will be chemically castrated. So they used to give still. So because of that, he mentioned that he had so much changes in his brain that he actually committed suicide. So this is something that this can have huge impact on the mood as well. So while it's very easy for somebody who has been influenced by the social media or whatever, that they are trans and they start estrogen, we should be very, very cautious. And that's why they talk about multiple steps psychiatric intervention. Because this sudden changes in your brain, the estrogen goes really high, it's never been exposed to those levels, can have a huge problem.
Yes, sir. And the monitoring during the induction of puberty is very important. The parameters that has to be monitored is the anthropometry, that is to be monitored 3 to 6 monthly. Blood pressure, as this estrogen will increase the high blood pressure, even the testosterone. In the transgender males, the hematocrit, lipids, testosterone levels, vitamin D levels has to be monitored. And in the transgender females, prolactin, estradiol, and the vitamin D levels has to be monitored. And in both cases, bone mineral density has to be monitored by using DEXA. GnRH analogs are continued till gonadectomy in trans females. If trans female wish to stop the GnRH agonist, anti-androgenous like the spironolactone or cyproterone acetate can be used in its place. So what physical changes should we expect after the sex therapy? And what time will it take? Let's see. The education regarding the onset and the time course of physical change induced by the sex hormone therapy should be given to each and during each and every session. And it is the masculinizing effect in transgender females would be the first during the first 6 months. There will be skin oiliness, acne, fat redistribution, cessation of menses, clitoral enlargement, vaginal atrophy. And in the next 6 to 12 months, there will be facial and body hair growth, scalp hair loss, increased muscle mass, and deepening of voice.
So typically it will take around 2 years.
2 years last time.
The other thing to remember that when you're analyzing them, many of them do not really want these sort of hormonal changes. They just want some basic suppression.
Basics, yes.
So you have to ask what their goals are and then go accordingly.
And in the feminizing effects in the transgender females will be like in the first 1 to 3 months, there will be decreased sexual desire and the decreased spontaneous erections. And in the 3 to 6 months, there will be decreased testicular volume, increasement of the breast tissue growth, redistribution of the body fat, decrease in the muscle mass, and but there will be no changes in the voice. The voice will be same, and they has to take the voice therapy for the voice change. So how should we monitor?
They can be fertile for some time. This is an important factor to
till gonadectomy, if you don't till surgery, How should we monitor transgender persons on the sex hormone therapy on a long run? So in the transgender male, to monitor appropriate virilization and any adverse reactions, 3 monthly in the first year and 1 to 2 times per year. Serum testosterone 3 monthly, and it has to be done midway between 2 injections. The target level is 400 to 700. Measure hematocrit and hemoglobin level at baseline 3 monthly and then yearly. Monitor weight, blood pressure, and lipid profile 3 monthly. Screen for osteoporosis when they are non-compliant to the treatment and when there is a risk for bone loss. This ovariectomy can be considered after the completion of the hormone transition, and conduct sub and perioral annual birth examination if mastectomy is done, and if mastectomy is not done, then do the annually mammograms. In the transgender female, to monitor appropriate feminization, 3 monthly examination, 3 monthly monitoring is done in the first year and then annually. Serum testosterone less than 50 nanogram, and the target level of estradiol is between 100 to 200, and it has to be done 3 monthly. If on spironolactone therapy, then monitor the serum potassium levels 3 monthly in the first year, then annually. Routine cancer screening is recommended, BMD at baseline, and screen for osteoporosis. and periodically monitor serum prolactin as the estrogen administration increase the prolactin levels. So when should the genital gender affirming surgery should be done? Again, for the surgery, the individual has to fulfill the criteria. We cannot just advise just go for the surgery. There are certain criteria that has to be fulfilled, and they are persistent and well-documented gender dysphoria, legal age of majority in the country, and having continuously and responsibly used gender-affirming hormones for 12 months, successful continuous full-time living in the new gender role for 12 months. If significant mental health concerns are present, they must be well controlled, and demonstrable knowledge of all practical aspects of surgery.
This is important. It's not a short term. You have to tell them the people. It will take a couple of years at least to achieve that hormonal status, and then it may take 1 year more to further follow up. So this is a long-term therapy, and we have to decide what they really want, and then keep on having a regular follow-up with the psychiatrist.
And the surgery that has to be done in transgender male is gonadectomy and hysterectomy if there is no plan for the fertility in the future. Mastectomy, reconstructive genital surgery. For the transgender male, for the transgender female, gonadectomy, removal of the penis, reconstructive genital surgery, breast augmentation, removal of the facial hairs, and the voice therapy is required. And endocrinologist should monitor transgender persons after gonadectomy for hormonal replacement. So now going back to the case, our 22-year-old female who was diagnosed with the case of gender dysphoria, yes, she fulfilled all the criteria for pubertal suppression, yes, and we started her on injection Leuprolide 11.25 milligram IM 12 weekly. Now our next plan, we are giving regular sessions for counseling. Now our next, after the complete pubertal suppression, our next plan, whether she fulfills the criteria for gender-affirming hormone therapy or not. And if she fulfills, our next plan will be to start the sex hormone therapy on her.
So I think this was a very good summary of the recommendation. The key message is that we need to be very careful about whether this particular individual who has come to us with gender dysphoria meets those criteria, and we don't get swayed by that. And then it's a stepwise process. Every step, our role is, if you talk about it's more like mechanical. We're just trying to suppress one hormone, adding another hormone. The key decision maker is actually the psychiatrist. So we are part of the team, but it's going to be not the main role. That is important. And a lot of people now are thinking that puberty blockers, as they are mentioned, GNR channel of people call puberty blockers are an easy thing you should do in everybody. We have to be cautious in that perspective. Okay, so Dr. Tawfiq is asking, suppression treatment is recommended before puberty. Counseling will be given by parents. What if child changes his mind and complain that they have not consented for treatment? So this will depend upon the legal status of every country. We definitely see, before puberty, why would you suppress is again a debatable issue. So we should really strongly discourage that. And even for DSD now, people are talking about that you should do interventions after they become mature. So this is a big legal issue. There's a big social issue. So we should be very, very careful in whatever we are doing. And that will be an important factor to consider. You can all go and have a look at our website, our courses which are available, and the mobile application. So